Then the question is, do we have good therapies? And we know that we have very effective therapies that are well tolerated for treatment of multiple myeloma. And the question is whether some or all of it can be used in the setting of smoldering disease, particularly in patients with a high risk of progression. And finally, we need prospective trials to show that early intervention actually makes an impact. And now we have 3 phase 3 trials that have shown that early intervention is beneficial. Yeah, the GRIDEX trial that looked at lenalidomide dexamethasone demonstrated the reduction in progression-free survival and improvement in overall survival. The caveat to that study was advanced imaging was not used, so a significant number of these patients may actually have active myeloma at the time of study enrollment. Subsequently, the ECOG trial looked at lenalidomide alone versus observation, and this was well-done study looking at advanced imaging, and again showed that in the patients with high-risk smoldering with a 20 to 20 criteria, the early treatment with lenalidomide led to improved progression-free survival or increase in the time to progression to active myeloma as defined by CRAB features. More recently, we had the Aquila trial that looked at daratumumab as a single agent versus observation in patients with high-risk myeloma, defined by a variety of different methods in addition to the 20 to 20 criteria metrics. This trial also showed that we can delay the onset of myeloma, but also showed that there's increased overall survival for patients who are getting daratumumab. So I think the sum of evidence at this point, the preponderance of evidence point towards early intervention being helpful in patients with high-risk smoldering myeloma. Now, the question that faces us is that does everybody with high-risk smoldering myeloma need an early intervention approach with one drug, or are there patients amongst them who may benefit from a myeloma therapy with 3 drugs? And ongoing trials like the Ithaca trial and the DETER SMM trial are looking at daratumumab-len or isatuximab-len combinations. In addition, there's also the whole concept of early intervention leading to potential cure at this early stage. So trials have explored that, like trials like the GEM-CSAR trial and the ASCENT trial looked at intense therapy given for a short period of time, similar regimens to what we use in myeloma with the GEM-CSAR, including a stem cell transplant. These trials have shown that we can get deep responses, MRD negativity, which can be sustained in patients with smoldering multiple myeloma, but they don't yet give a definitive idea whether we can cure some of these patients. So ongoing studies are looking at some of the more recently introduced immunotherapies to see if we can actually eradicate the clone in some patients. So in summary, I think we have significant amount of data that have come up over the past decade, which tells us that we can define the population who is at high risk of progression to myeloma and intervene in them with therapies that are quite safe, reducing the risk or delaying the risk of progression to myeloma, and possibly curing or eradicating the underlying clone in at least a small proportion of these patients.